Well, that's why you need to check the footboard before the patient comes in. So, other thing that you want to do is I don't know who does the QA or systems checks in the morning, but somebody needs to check the floor room in the morning to make sure that everything is operational. There's nothing worse than getting your patient ready, getting the patient set up, you've done your scout, because the scout is not done by your fluoroscopic machine, it's done by your x-ray machine. Okay? So there's nothing worse than doing your scout, getting your patient ready, prepped, ready to go, you call the doctor in, pulls the fluoro tower across, and all of a sudden it's not working. Okay? So, footboard, equipment, monitor, make sure everything's working. Have your lead aprons available, have your barium, any accessories that's necessary for that test, have it readily available, and always expect the unexpected. Okay? Always expect the unexpected. So we'll also do a procedure of the esophagram to evaluate for esophageal reflux. What is reflux?
Backflow.
Yeah, everything comes back up. Okay? So there's something going on with the mechanism at the cardiac orifice of your esophagus and stomach that isn't acting properly. The valve isn't doing what it's supposed to do, and everything is coming up. That's reflux. That's heartburn. You guys know heartburn? Yeah. This is heartburn. Okay, so all the gastric juices are coming up, and you're feeling it right here. That's heartburn. That's acid. Okay, so esophageal reflux. So to determine esophageal reflux, there's a couple of ways to evaluate for this. So one of them is one of the maneuvers that we do involves a breathing exercise. The first one here is a Valsalva maneuver. So the patient is going to drink contrast. Okay. Oh, good. Okay. Thought you were going to explode. They're going to drink the barium. So now the barium is in their stomach. So what we're trying to do is create this intra-abdominal pressure to force the contents back up into the esophagus. So one way to do that is during fluoroscopic observation, they take the contrast. The doctor's going to ask them to take a deep breath in and bear down. Hold your breath and bear down. So you're increasing the intra-abdominal pressure. Hopefully it'll come up. Another way is called the modified Valsalva maneuver, where you pinch your nose, close your mouth, and blow. Same thing as this, same as Valsalva. The key here is you're trying to blow out. The Mueller version is the opposite. You breathe out, and then you try to inhale in. Okay, so these are the breathing exercises. Now the most common one that we do here is the water test. The water test. So the patient drinks the contrast. They're laying flat on their back. They're in an LPO position. So they are oblique like this on the table, and they're holding the cup of water as they're laying down, and they're drinking water. If they have reflux, where's the fluoroscopic unit going to be? Where is it going to be positioned? Is it going to be positioned up here? Where are we looking for reflux?
The distal.
Where the esophagus and the stomach meets. Okay, so the fluoro tower will be right over where the stomach and the esophagus meets. So when they're drinking the water, someone who tests positive for reflux, you will see a volcano eruption. Literally, you will see contrast from the stomach making its way up the esophagus. So this is the most common type of test, is the water test. Yeah, this is more dramatic than these. This is pretty cool to watch. Okay. The other one is by force compression. So patients on their stomach, or we have to kind of paddle and we're pushing down on them to cause the reflux to occur. Okay? And then there's the toe touch maneuver. What do you think that's all about?
Because they're touch your toes. Gravity. Self.
Yeah.
Kristen.
All right, any questions? All right, the upper GI. I know, just, what time do I have you till technically?
What number are we
And then
on?
again at 4:30.
Oh,
Our next call.
15-minute break.
You have us till 9 o'clock tonight.
I do.
Yes, you did.
Hopefully not, but yes, you do.
She meant to say 7:30.
Did we, who said 7:30?
No, I meant to say 3:15.
All right. Just bear with me. I've done this for many years. I know how to make you guys happy, so just bear with me, okay? Let's just go with the flow right now, okay? The upper GI. The purpose of the upper GI is to study form and function of the esophagus, the stomach, and the duodenum. Okay? Contraindications: bowel perforation, right? Laceration and also rupture. Here we have a PrEP. The PrEP is that the patient has to be NPO for 8 hours prior to the examination. What does that mean?
No eating.
NPO.
No eating or drinking.
No eating or drinking. This is also important, especially if the patient has diabetic history, right? Because now they can become very hypoglycemic and they can have a hypoglycemic shock or diabetic response in your department. For that, anytime we have a fluoroscopic study, we do them when? First thing in the morning, okay? So they're going to be NPO. No smoking or gum chewing. What is that all about? Oh, no vaping. No smoking, no vaping, no gum chewing prior to examination. Smoking and gum chewing increases your gastric juices. Okay, it increases your gastric juices. So if you give the patient barium, the barium cannot cling on to the mucosal walls. Okay? Now, I'm introducing this to you, but you will have the technologists asking them all these questions, but they'll never ask them if they've had anything to smoke or did they chew any gum before coming into the department. So again, this is for your guys' knowledge. Don't be surprised if they don't ask that question to their technologists, okay? I mean to the patient. Room prep, what did we say about room prep?
Check your
Check
equipment.
floorboards, check
Equipment,
Check the
monitor.
equipment, check the fluoro, check the monitor. Make sure you have all your contrast ready, have a bunch of cups, have a lot of straws, have shot glasses,
Cotton balls and marshmallows.
have some cotton balls, have some marshmallows, okay? Some candles, some soft music. We're ready, okay? So make sure your room is ready. Again, expect the unexpected, okay? Some of the things you're gonna ask this patient. You guys ready? Because it's gonna be part of your dialogue. Have you had this procedure done before? It's the usual. Have you had this procedure done before? If so, what did they find? Why are we doing this? Because sometimes it could be a follow-up to a procedure that they had previously. So why are we doing this? Have you had this done before? What kind of problems are you having? How long have you had this problem? Oh, I've had this stomach pain here for about 2 weeks. I've been vomiting, I've been throwing up. It's very acidic, things like that, okay? I'm coughing up blood, okay? So those are some things that you're gonna ask. Are you diabetic? Any chance of you being pregnant? The usual. Here's a new one, is are you having any other exams today besides us, okay? Because let's just say that we were going to have this barium study done, and then they had to go to CT to have another procedure done. Can they do it? No, because the barium's in there already. So we want them to have their CT study done first. We want them to have their ultrasound study done first before we do it. Because once the barium's in there, now you got to wait 2 or 3 days until the barium's gone to have those other procedures done. Same thing with surgery. Are you going to have surgery? Are you scheduled for any surgery in the next couple of days, Ms. Jones? Yes or no? If yes, what kind of surgery? Nasal septum. Anything else? Are you having any surgery done to your abdomen? If it's the nasal septum, do we care? If it's in the abdomen, do we care? Now we care, okay? Because if they're going to have surgery, we can't do a barium study. Here's another one. Did you recently have abdominal surgery? Because if they recently had abdominal surgery, they may not be completely healed. And if you're giving them barium, it's going to leak out. Now you're causing more problems. So you want to know if they're going to have surgery or if they've had recent surgery. Okay, that's part of your dialogue now. Oh,
There they are.
there you go. Yeah. Okay, there you go. All right, any questions? Okay, so diabetic patients schedule first, withhold insulin until after the examination. After the exam, you want them to take their insulin and eat. Again, if they do have a hypoglycemic reaction within your department, what should you have access to? Okay, Lifesaver, sugar packets,
Orange
carton
juice.
of orange juice, carton of apple juice. Okay.
Sugar.
Some sweet vape. Okay. All right. Do we all know how to recognize someone who's still going through a hypoglycemia? I'm going through one right now.
Yeah, me
Having one.
too. Yeah, me too.
Yeah. That's me. Blurred speech and slurred vision.
Blurred speech?
Blurred speech and slurred vision. Okay. Okay, a Bezor. A Bezor is any undigested material. Who has a Bezor? Do you know anybody who experiences Bezor? Do you know people who like to eat hair?
All those words.
Yeah. God, there's a show where they were showing this.
My
And I don't know if this was real enough. but it
Grey's
was-
Anatomy.
Huh?
It's Grey's Anatomy.
Grey's Anatomy. I've seen a
Strange
video
Addiction.
where some girl was eating a mattress.
Yeah.
Yeah.
She want to be a mattress.
He
Yeah.
ate 9 doll heads.
Oh, here's another one. Okay. Okay. How about those who like to eat coins?
Well,
People, yeah.
they got problems.
Yeah. It's a psychological problem.
It
So,
happened when they pregnant.
They're Bezors.
yeah. Those are Bezors. So Bezor is any undigested material. It will cause a filling defect. A diverticula. What is that?
Outpouching.
Outpouching. Emesis.
Vomiting.
Vomiting. Hemoptymesis.
Blood in the vomit.
Okay. So vomiting and also blood in the vomit. Gastritis. If you have inflammation. Any type of cancer. A hiatal hernia. You guys remember that first chest X-ray I showed you guys?
Mm-hmm. Had a
With
big
the
old.
stomach protruding through the diaphragm and into the chest cavity. Hiatal hernia. Schatzky's ring. I will show you a picture of what a Schatzky's is in just a minute. And you have ulcers. Okay. So here we have a hiatal hernia. There's the diaphragm, right? Okay. Fundus protruding through the diaphragm. An ulcer is in any open sore. I'm going to go through these real quick. I know you guys want me to.
Mm-hmm.
Okay, a diverticula. Be familiar between the difference between a diverticula and a diverticulum. Are they the same thing? Yes.
Yes.
One is singular, the other one's plural. Diverticula is plural, diverticulum is singular. Okay, it's an outpouching. Where is this outpouching located?
Pylorus.
What part of the stomach?
Pylorus.
Pyloric portion. Okay. Pyloric portion. Okay. There's another one right there. Okay.
Right there.
Right here, where the arrows are.
You're welcome.
Okay, Bezor. No, I don't see that. You don't see it? Well, look at all the little.
Hair.
Yeah. I think. I don't know.
Yarn.
Cotton balls.
Something not
yeah.
digested.
Here, let me create one like you put
Okay, Schatzky ring. Schatzky ring is a narrowing of the lower esophagus that can cause difficulty swallowing. The narrowing is caused by a ring of muscular tissue. Again, this is generally found in the distal area of the esophagus. My dad has a Shasky ring. He has to go
Why
have
does
his
that
esophagus stretched every 3 months.
Yeah.
Yeah. When he starts losing weight, that's when I know it's time for him to go to the hospital. Yeah, because of that.
Some esophageal stretching.
Yeah, because he doesn't have an appetite. He doesn't want to eat. He says he can't swallow.
Why
So,
they don't cut that part and reattach the?
It's my dad has medical histories. He has issues. It's my dad. Yeah, he's not strong enough to have those type of surgeries. So we avoid it. All right, what are we looking at here?
The rouge.
Rouge. Does it look kind of funky looking?
Mm.
It shouldn't be like that. They look very thickened, right? Very thickened. So this is gastritis. And then here we have a perforation. Here's the stomach, right? Look at all this. It's leaking inside the peritoneal cavity. This is not bowel, because if this was bowel, we should see the small bowels filling up with contrast. But there's no filling up here. Everything is leaking on the outside. So it's actually attaching itself to the peritoneal wall.
Is that because they were laying on the right side, and so it went down to the right?
It doesn't matter if you're laying down, it's gonna leak somewhere. That's actually a good point, but no, that's not the reason why. All right, so here are the positions for an esophagram. What's the first thing we're gonna do before we even do this?
Scalp film.
Take a scalp film. What's a scalp film? It's just a regular chest x-ray, guys. 14 by 17, crosswise or lengthwise, however you guys do in your hospital. Where's the central ray directed?
C6 or
Not C.
no T.
T7, okay, T7, all right. So now the patient's gonna come in, we're gonna tell the patient what we're gonna be doing. They're gonna be drinking some barium, okay? Prep is remove everything from the waist up so nothing is in view. First view here is an RAO position. Now, I'm gonna regress here just a little bit, okay? This is done as a fluoroscopic study, which means that the same positions that you're gonna see here is usually also done by the doctor. So the doctor will come in, he'll put these patients in the same position, have them drink the contrast. And then he'll take his spot films or fluoroscopic shots. Now, after he or she is done with that portion, this is where there might be some variations. The procedure may be just, you're done. Or, in some facilities, they're gonna have you do overheads, your regular x-rays. So, usually it's broken down to a fluoroscopic study and then a radiographic study. Motion, still shots. Okay? Now, why would you still do the radiographic portion part of it? Because in fluoroscopy, you're only taking sections of it, so you're not getting the entire esophagus on an image. And that is why the doctor may ask you to take some overhead so you get the entire esophagus on one image receptor. So again, this is where the variations are gonna occur. What I'm showing you guys here are the overheads after the fluoroscopic portion has been done. So the doctor comes in, patient's drinking, he's taking the spot films in all the different areas of the esophagus while the patient is laying down in different positions, including in an upright position. Now he leaves and you're gonna do your overheads. This is an RAO esophagus. You're gonna have a cup full of barium. You can either do it in a prone position, prone RAO, or an upright RAO. Okay? So patient is going to be rotated between 35 to 40 degrees. The central ray is going to be centered at the level of T5, T6. We know where T6 and 7 is, right, for a chest x-ray. So now we're going to go up a little bit higher because we said the esophagus top of the esophagus is right about here, right? This is T6, T7, top of your image receptor. Now we're going to include this area. So now we're going to go up a little bit higher to include the most proximal of the esophagus. Okay? So the esophagus, remember, is just anterior to the spinal column. So if you see where the spinal column is, just slightly go in front of it and you'll be right down on top of that esophagus. It's not between here and here. It's not between here and here. Okay? It's going to be right off my spine. Does that make sense? So it's right off the spine on the upside. Now, as you're getting ready here, you're going to put the straw in their mouth. They're not drinking yet. Okay? Because this is what's going to happen. I'm going to set them up. And as they're set up, I'm going to be doing this. Drink and swallow, drink and swallow, drink and swallow, drink and swallow. Keep on going. Drink and swallow, drink and swallow, drink and swallow. Click. Okay? You just don't have them drink. Okay? Because you don't know. They'll probably just take one swig. You want to tell them to continuously drink, because if you've ever seen contents like contrast go down the esophagus, it just goes zip.
No.
It's just gone. So that's why you have them continuously drink. And you're watching them and you're making sure that they're drinking. And as they're drinking, that's when you're going to hit the exposure button. Okay? Can they hold their breath? Just drink and swallow, drink and swallow, drink and swallow. Click. Watch them. Okay? All right. So it's going to be a large image receptor. Do I need the entire image receptor on there? Esophagus is what? It's like this.
Mm-hmm.
So collimate to about a 7 by 17. Collimate to the width with some extra space for the esophagus, about 7 by 17. Okay? Any questions? It's going to look like that. So the whole purpose of this REO, it's a good projection because it shows the cardiac antrum. It shows the cardiac antrum, but it's also very good in that it takes the esophagus away from
Spine.
the spine. Okay? In an AP or PA, it's right on top of each other. So this is the best view for that. It takes it away from the spine and also shows the antrum. Okay? Drink and swallow, drink and swallow, drink and swallow. Got it? Okay. Lateral esophagram. Lateral. Whatever your department does, they can do it right lateral, they can do a left lateral. It's up to them. Okay? But it's a lateral. Same thing applies here. So central ray is going to be at the level of T5, T6, so it's slightly higher than a chest X-ray. Collimate to an area of 7 by 17. 7 by 17. You know where the spinal column is. Just center right in front of the spinal column. Not here. My esophagus is not here. My esophagus is back here somewhere in front of my spinal column. Okay? So slightly in front. They're laying on their side. You say, now I'm going to have you lay on your side. I'm going to have you put your one leg over the other, put your other arm on top of the other, just like you were praying. Assist them, put the cup by in front of them, put the straw in their mouth, and then same thing. Drink and swallow, keep drinking, keep drinking, keep drinking, okay, keep drinking, click. And you're watching them. All right? Questions? Is shielding important? Should I still shield? Just shield. Shield all your patients. Okay. So here's the lateral. All right? See how it kind of follows the spine? Right anterior to the spine. All right. Now, if you can get the entire esophagus on here in one shot, from throat to the stomach, you're badass. Because it's very rare that you get the entire esophagus on there in one shot. Because during the drinking and swallowing, there may be a gap where the esophagus is not filling. And if you just get a small portion of the esophagus with just barium and everything else is black, they're going to have you repeat that again. So you want to try to get as much of the esophagus on there. Will you get the entire esophagus? Maybe not always, but you can get about 80% of it in, you're good to go. Okay? Okay. So this is the optional swimmer. So if you have somebody very, very thick and burly and they're trying to do a lateral position, they may be too thick to visualize the esophagus. So what you do is you just kind of roll the shoulders back a little bit. Okay, so get the shoulder out of the way. They're still in the lateral position. All you're doing is just rolling the shoulders back. Okay? And then here's your AP. We still have to do an AP. Why not PA? Why is AP better than PA?
Because it's
Because it's closer to the, yes, because it's closer to the image receptor, okay. So, a little higher than the chest x-ray, collimate to about 7 by 17, have them hold the cup, turn their head, drink and swallow, drink and swallow, drink and swallow. Yeah? All right. Ta-da. All right, views for an upper GI. Views for an upper GI. Okay. These are your views, RAO, PA, right lateral, LPO, and an AP. Same thing applies here. So you're gonna set up the room, make sure everything's set up in place. You're checking the footboard, floor is working, monitor's working, you've got your barium, you've got your gas crystals. Okay? So patient goes to the room, remove everything from the waist up. They're gonna come into the room. I'm gonna sit down, explain the procedure to them. What is the first thing I'm gonna do? Before anything else?
Scalp film.
Scalp film, okay? You gotta do a scalp film. Now the scalp film here is a KUB, but it's a high KUB, which means that it's not gonna be centered at the iliac crest. It's gonna be 2 inches above the iliac crest, because what are we looking at here? What are we trying to include?
Diaphragm.
Okay, we've got the stomach. So we want to look more of the stomach. What happens if we cut off the symphysis pubis? Because that is a criteria for a KUB, right? If I go up higher, am I not going to cut the symphysis pubis? Yes. Is that okay? Yes. Okay, that's the exception. So 2 inches above the crest to include the stomach. That's your KUB. Show that to the doctor. Give the doctor the patient's history. Go back into the room. What's your next step? Okay,